Evening, and thank you for being here. Today, I will be presenting my DMP Quality Improvement Project, which focuses on implementing a COPD discharge care bundle and evaluating its impact on 30-day readmissions. My committee members include my DMP chair, Dr. Sauer, 707 course faculty, Dr. Snell, and my community member, Dr. Frank Farkish, who's CNO of the organization. The aim of the project was to evaluate whether implementing a COPD discharge care bundle at a rural community hospital reduces 30-day readmission rates compared with pre-intervention outcomes. Some background, COPD is a major public health challenge associated with high morbidity, mortality, and healthcare utilization costs. Acute exacerbations are the leading driver of emergency department visits, hospitalizations, and early readmissions, accounting for approximately 700,000 hospital admissions and a 20% 30-day readmission rate each year in the United States. These exacerbations represent the most critical health status impairment among the COPD population, contributing to increased costs, worsening symptoms, and premature death. Nationally, COPD accounts for an estimated $50 billion in annual healthcare spending, with about 70% of costs attributed to exacerbations that require hospitalization. In response to the burden, CMS added COPD to the HRRP in 2014, which provides financial incentives to hospitals to reduce preventable readmissions and improve care transitions. Despite these regulatory pressures and the availability of evidence-based guidelines, many hospitals continue to experience high COPD readmission rates due to gaps in discharge planning, inconsistent patient education, inadequate follow-up, and failures in care delivery. More than 25% of COPD readmissions are attributed to preventable causes related to some suboptimal care processes, including poor inhaler technique instruction, lack of smoking cessation counseling, insufficient medication reconciliation, and absence of timely follow-up appointments, as well as pulmonary rehab referral. The literature consistently demonstrates that discharge care bundles, which are structured sets of evidence-based interventions, can significantly reduce readmissions when they are implemented reliably. Discharge care bundles are a well-established, evidence-supported strategy for improving patient outcomes and reducing hospital readmissions. The literature consistently demonstrates meaningful reductions in COPD readmissions following bundle implementation, with reported decreases from 22.7 to 14.7%, 23.3% to 15.8%, and 21.7 to 11.8% across multiple studies. The IHI states that a bundle is a structured way of improving processes and care patient outcomes. And they are a small, straightforward set of evidence-based practices, genuinely 3 to 5, that when performed collectively and reliably have been proven to improve patient outcomes. COPD is a major contributor to morbidity and mortality, and remains the third leading cause of death worldwide in the United States. And as mentioned, approximately 700,000 hospitalizations for acute COPD exacerbations occur each year, with readmission rates near 20%. Patients who are readmitted often experience worse outcomes, including mortality. These frequent hospitalizations and emergency department visits significantly drive healthcare utilization costs, which are estimated between 50 to 72 billion annually. Because exacerbations and readmissions escalate as the disease progresses, interventions such as structured care bundles are believed to improve care transitions, reduce readmissions, and ultimately decrease healthcare spending. There are several key factors that influence 30-day readmissions. Comorbid conditions such as hypertension, diabetes, coronary artery disease all significantly increase the risk of 30-day readmissions, along with additional factors such as home oxygen use, prior hospitalizations, smoking status, nutritional status, health literacy, and age. Transitions of care also play a major role. Inadequate follow-up or missed appointments and unclear discharge plans are common contributors to early readmissions. Care delivery factors further compound this risk, with more than a quarter of readmissions linked to suboptimal care, such as confusion about inhalers, inadequate medication regimens, poor discharge instructions, lack of smoking cessation counseling, insufficient home medications, and outdated vaccinations. Together, these patient level, system level, and care delivery factors highlight the complexity of COPD readmissions and the need for structured, reliable discharge processes. For this project, my care bundle did have 6 components. Those included assessment of medication regimen, inhaler technique assessment, smoking cessation, referral to pulmonary rehab, assessment of social determinants of health, and outpatient follow-up appointment. This evidence is further reinforced by the Global Initiative for Chronic Obstructive Lung Disease, or GOLD 2026 guidelines, which provide clear, internationally recognized recommendations that align directly with the bundle's elements and strengthen the rationale for implementing this intervention. The GOLD 2026 guidelines provide strong evidence-based support for COPD discharge care bundles implemented in this project, reinforcing both the clinical relevance and expected effectiveness of each bundle component. GOLD emphasizes that preventing exacerbations, optimizing pharmacologic therapy, and strengthening transitions of care are central to reducing morbidity, mortality, and hospital readmissions, precisely the practice gap this project aimed to address. GOLD identifies optimized pharmacologic management as a foundational element of COPD care, recommending assessment of inhaled bronchodilators and corticosteroids at discharge to ensure alignment with current disease severity and exacerbation risk. This directly supports the bundle's inclusion of pharmacologic regimen assessment and medication reconciliation. GOLD also stresses that incorrect inhaler technique is a major contributor to treatment failure, recurrent exacerbations, and avoidable readmissions. The bundle's inhaler technique evaluation aligns with this guidance and addresses a well-documented high-impact risk factor. Smoking cessation remains one of the most effective interventions for improving long-term outcomes, and the GOLD guidelines recommend that cessation counseling occur at every clinical encounter. Including smoking cessation evaluation and education in the bundle reflects this priority. GOLD also highlights pulmonary rehab as a key post-hospitalization intervention, citing improvements in dyspnea and functional status, as well as reduced readmission rates. The bundle's referral to pulmonary rehab is fully consistent with this evidence-based recommendation. Timely post-discharge follow-up is another GOLD priority, as early outpatient evaluation reduces complications, supports medication adherence, and improves continuity of care. The bundle's requirement to arrange follow-up appointments directly reflects this standard. Finally, the GOLD 2026 places increased emphasis on social determinants of health, recognizing that transportation barriers, financial strain, medication access, health literacy all significantly influence COPD outcomes. Incorporating the SDOH screening and resources into the bundle aligns with GOLD's expanded focus on equity, individualized care, and addressing non-clinical contributors to readmissions. When we look at this slide, we can see how Lewin's change theory served as the backbone for the entire COPD discharge bundle project. And even though our outcomes didn't fully meet the expectations, and we encountered several barriers that I'll discuss shortly, Lewin's framework still provided the structure and foundation that would help guide each phase of work. It helped organize the project, shape our approach to change, and ensure that every step was grounded in a systematic, evidence-based process. Lewin's change theory consists of three phases: the unfreeze, change, and refreeze phases, which provided framework for addressing rapid change. The unfreeze stage aligned with the early phase of the project, where we identified the core problem, our high COPD readmission rates, and recognized the need for a structured, consistent discharge process. This phase was about building urgency, engaging staff, and preparing the clinical environment for change. It helped create buy-in and set the foundation for why the discharge bundle was necessary. The change phase reflects the active implementation of the COPD discharge bundle. This is where education, workflow refinement, and troubleshooting occurred. Staff learned how to use the bundle. We clarified roles and we addressed barriers in real time, or that was the goal of the model. Again, we'll discuss some of those barriers here in a bit. Lewin's model guided us to expect discomfort and adjustment during this phase, which helped frame staff feedback as a normal part of the change process rather than resistance. Finally, the refreeze stage showed how we approached sustainability. This meant hardwiring the new discharge process, monitoring compliance, reinforcing the benefits, and ensuring the bundle became a part of routine practice rather than a temporary initiative. This phase influenced how we structured follow-up, documentation, and evaluation. For this project, a pre and post quality improvement design guided by the PDSA framework was used. This approach allowed me to introduce an intervention, observe its impact over time, and evaluate feasibility within real clinical workflows. The project took place in a 165-bed rural community hospital that includes an ICU, a progressive care unit, and a med-surg unit. This setting was important because it reflects the typical environment where COPD readmissions remain a challenge. The intervention, as previously mentioned, was a 6-component COPD discharge care bundle that included assessment of pharmacologic regimen, inhaler technique, smoking cessation, counseling, referral to pulmonary rehab, timely outpatient follow-up, and screening for social determinants of health. These components were selected because they are evidence-based and align with the national priorities and GOLD guidelines. For implementation, the bundle was developed with support from nursing leadership, the COPD navigator, and the chief nursing officer. Staff education was delivered exclusively through email, as an in-person training was not permitted. A standardized discharge checklist was created to support bundle use, but it was ultimately not adopted by the organization. These factors influenced how consistently the bundle could be applied. The primary outcome for this project was 30-day all-cause hospital readmissions, which directly aligned with the project's inquiry question and allowed evaluation of the bundle's impact on care transitions. The setting, as mentioned, the quality improvement project was conducted at a rural community hospital in Southwest Ohio. It was a 165-bed facility. The project was implemented in the ICU, a PCU, and med-surg unit. To mention, the organization does have an emergency department and 2 behavioral health units, but those units were not included in the project design. For this project, the intervention focused on evaluating the differences in the discharge process between 2 groups: a control group that received the organization's discharge procedure and a test group that received the revised discharge care bundle. The hospital's COPD nurse navigator provided the number of patients admitted and then subsequently readmitted during the designated timeframes. August to October of 2025 for the control group, and then November of 25 to January of 26 for the test group. The final sample comprised of 73 patients in the control group and 81 in the test group. Outcomes were assessed by comparing 30-day readmission rates before and after implementation of the discharge care bundle, allowing for a direct evaluation of its impact on transitions of care for patients hospitalized with COPD and providing a numerical basis for comparing readmission outcomes between the two phases. All individuals included in the analysis were adults age 18 and older and were admitted with the same COPD-related diagnosis, ensuring consistency across the groups. For this project, the quantitative analysis focused on determining whether the COPD discharge care bundle produced a meaningful reduction in 30-day hospital readmissions. Because the primary outcome, readmission versus no readmission, is a categorical dichotomous variable, the z-test for the difference of two proportions was selected as the appropriate inferential method. A lower tail z-test was used to evaluate whether the proportion of readmissions in the post-implementation group was significantly lower than the proportion observed in the pre-implementation group. This directional approach aligned with the project's aim of reducing readmissions and allowed for a clear statistical comparison between the control and intervention periods among the adults with the primary COPD diagnosis. This slide displays the previous data as a pie chart for a clearer visual representation. For the study, a lower tail z-test for the difference of two proportions was used to evaluate whether the 30-day readmission rates differed significantly between the control group and the test group. The control group, which received the standard discharge process, demonstrated a lower 30-day readmission rate, 7%, when compared to the test group, which received the partially implemented discharge care bundle. Their readmission rate was 19%. This difference was not statistically significant. The z-test for the difference of two proportions demonstrated that there was no statistically significant reduction in 30-day COPD readmissions following implementation of the discharge care bundle. The post-implementation group had a higher readmission rate compared with the pre-implementation group, yielding a test statistic z-score of 2.1510 and a p-value of 0.9843, which does exceed the significance threshold of 0.05. These results indicate that as implemented, the discharge care bundle did not achieve the intended improvement in readmission outcomes. The 95% confidence interval for the difference between proportions further suggested that the true change likely reflects an increase rather than a decrease in readmissions. Additionally, the study's achieved power was low, indicating a limited ability to detect a true effect, even if one existed. Several limitations significantly affected the fidelity of this project. When we consider these limitations, several factors affected our ability to fully implement and evaluate the COPD discharge bundle. First, there was an organizational shift in focus partway through the project, which resulted in only partial implementation of the bundle. The organization decided to shift from all 6 components to focusing really solely on the SDOH aspect. This really limited our ability to assess the full impact. Education also was only delivered through email, which reduced the opportunities for hands-on training, clarification, and real-time engagement with staff. In addition, we faced a lack of stakeholder buy-in, which affected the overall participation and consistency in using the bundle. Finally, the short implementation period restricted time needed for staff adoption, workflow refinement, and meaningful outcome measurement. Despite the project's outcome, several key facilitators and strengths supported its launch. Strong leadership from both the CNO and the Director of Quality provided early momentum, organizational alignment, and the necessary support for the implementation. Interdisciplinary meetings held prior to rollout helped establish collaborative engagement, clarify workflows, and proactively address some of the system level barriers. The project was evidence-based and grounded in current literature, aligning with national priorities to reduce COPD readmissions and fully consistent with the GOLD guideline recommendations for improving care transitions. Together, these strengths created a solid foundation for implementing the COPD discharge care bundle and reinforced the project's relevance to both organizational and national quality goals. Several barriers and unintended consequences emerged during the implementation of the COPD discharge care bundle. Um, the bundles, again, we weren't able to implement the whole bundle, and the facility wanted to focus solely on the SGOH portion, and this change was just prior to the rollout when they shifted their priorities. The last minute change created confusion among staff and disrupted the consistency of the intervention, as some team members believed only the SGOH screening was required rather than the complete bundle. Additionally, although the intervention was designed to streamline and standardize the discharge process, staff perceived the added steps as increasing workload during an already demanding shift. This perception contributed to limited buy-in and inconsistent adoption. The restriction to email-only education further compounded these challenges, as the inability to provide in-person or formal training reduced opportunities for clarification, reinforcement, and hands-on support. The lack of full interdisciplinary engagement, particularly from stakeholders who either disagreed with or were minimally involved in the process, also introduced variability in how components were completed. Despite the non-significant results, the project revealed critical gaps in workflow, staff buy-in, and organization alignment that must be resolved before the bundle's true impact can truly be measured. When we look at the implications for practice, this project highlights how a structured, evidence-based COPD discharge care bundle can meaningfully improve patient outcomes and strengthen the way we deliver care. Having a reliable, standardized process ensures that every COPD patient receives the same high-quality education, follow-up planning, and transitional support, which reduces the variability that often lead to readmissions. For patients, this means clear instructions, better symptom management at home, and improved continuity of care after discharge. At the healthcare system level, consistent implementation of discharge bundles help close coordination gaps and reduce system-level failures that contribute to avoidable readmissions. This project also reinforced how essential interdisciplinary collaboration among nurses, respiratory therapists, pharmacists, providers, and case management is in making the bundle work. Finally, the workflow barriers we encountered, including the communication challenges and limited staff engagement, emphasize the need for strong organizational support, adequate training, and clear expectations. When these elements are in place, nurses are empowered to perform discharge responsibilities effectively, and the entire care team is better positioned to deliver safe, reliable, and patient-centered transitions of care. This project examined whether implementing an evidence-based COPD discharge care bundle that aligns with national priorities and GOLD guidelines could improve 30-day readmission outcomes. Although the intervention did not reduce readmissions, the process revealed that structured discharge practices are feasible and can be integrated into clinical workflows when supported by leadership and interdisciplinary collaboration. The implementation experience highlighted critical lessons related to fidelity, staff engagement, and the importance of hands-on interactive education rather than relying solely on email communication. These insights provide valuable direction for strengthening future iterations of the discharge bundle and improving care transitions for patients with COPD. If I were to do this project again, I would prioritize earlier stakeholder involvement, provide more robust in-person education, and ensure stronger accountability for bundle completion. I would also refine the discharge process by expanding staff training and working towards full integration of the bundle into routine practice to achieve greater reduction in COPD readmissions. On a personal level, completing this project and the DMP program as a whole has had a profound impact on my growth as a clinician and leader. I have strengthened my skills in evidence based practice, data analysis, quality improvement, and interdisciplinary communication. Most importantly, I have gained confidence in my ability to design, implement, and evaluate system level changes that improve patient outcomes. This experience has shaped me into a more thoughtful, strategic, and forward thinking provider, and it will continue to guide my practice as I transition into my role as a DNP prepared nurse practitioner. Here's a list of my references. Thank you for your time, and I appreciate the opportunity to share this work with you. Have a good evening.